So, okay, so now we'll go into gout, which is kind of like the last topic for this series. So yeah, back in the day, they didn't really know what gout was. They thought, some kind of like evil, satanic, gargoyle creature that came and stabbed you in the foot, and you couldn't walk for several days. And it's probably not too far off because it is quite painful. But it is a heterogeneous clinical spectrum of diseases that we are associated with elevated serum urate concentrations. And so the patients present with hyperuricemia, and these these serum urate rates can be higher than 6 milligrams per deciliter for women, or 7, it should be milligrams, not MF, milligrams per deciliter for men. That's really the most important risk factor, is elevated urate. We see recurrent attacks of acute arthritis with these patients. With the urate crystals within the synovium, you see monosodium urate crystals, and a lot of these crystals can be deposited in various joints and tissues. There's also a interstitial renal disease component of it, and of course a kidney stone component to it. And as Dr. Shaw had mentioned, it's historically classified as a disease of kings, typically associated with gluttony and an inactive lifestyle. And actually that's not too far off when we consider some of these underlying things that can favor the development of gout. We find it more commonly in the developing world, of course. We're lazier, right, than developed countries. And we also see it more common in the aging population, people that are less active, people that are obese or somewhat obese, and men are sometimes more affected with it than women. So understand that uric acid is the final step of purine degradation. So we're talking about the catabolism of purines, and the byproduct of that is uric acid, and that's a waste product. And so several conditions that exist can actually precipitate hyperuricemia, and that can eventually lead to gout. Okay, and so it's a cycle, it's a vicious cycle between an amplification phase, where there's tissue damage, a resolution phase, which is strongly the immune system drives it, and then there's a quiescent phase, which is all quiet until this phase with uric acid crystal recognition becomes activated. So it's a vicious cycle that's basically summarized here. You can read the figure legend underneath. So lots of conditions are associated with hyperuricemia. You can read those here by yourself. And there are drugs that are associated with inducing hyperuricemia and gout: levodopa, ethanol, cyclosporine, diuretics. And so, for the patients that we try to manage, as Dr. Shah was alluding to, we see incidences of gout attacks being increased during the holidays, when people are stuffing themselves on all kinds of rich food. And what else do you do during the holidays? Because you're with your families. You drink, right? So lots of high meat in the diet can lead to ingestion of proteins. Proteins become broken down into purines, and purines favor the formation of these uric acid crystals. Having particularly beer on board, but also other ethanols, can exacerbate the production of uric acid and lead to a gout attack. All right. So gouty arthritis is produced by the deposition of these uric acid crystals within the joint, and that's in response to the hyperuricemia that exists. And then there's an acute inflammatory episode that produces the pain, swelling, and inflammation that we see, that the patients complain about, that basically reduce their ability to walk and stand and essentially be functional. So the main objective is to really terminate the inflammatory episodes that produced these acute inflammatory mediators, and of course reduction of the hyperuricemia. And you can imagine what the drug classes are that can potentially reverse either of those two objectives. So your anti-inflammatory agents include, the classic colchicine, as well as your NSAIDs like indomethacin and ibuprofen. And these drugs will essentially stop the inflammatory episode through the different mechanisms that we've been talking about. We can employ the use of uricosurics, such as probenecid, and that's going to inhibit uric acid reabsorption. And the outcome or the consequence is going to be a reduction of uric acid within the blood. There are other drugs called xanthine oxidase inhibitors. Allopurinol is probably the more commonly encountered one. Febuxostat is a newer agent. And the outcome, or the mechanism here is we're going to inhibit xanthine oxidase, and that will reduce uric acid levels within the blood. So two different mechanisms can achieve reduction of uric acid levels. And this is kind of a nice summary chart of different pathologic processes that drive or exacerbate gout, and the drug classes as to where they inhibit. And so we'll pull this apart in various examples throughout this lecture, and you can come back to it to review. So with the goal of terminating the inflammatory response, the nice thing about this is that it offers essentially immediate relief of the gout attack. And the main agents that are used, that are employed in this objective include ibuprofen. We don't really want to give aspirin because there's a renal component to that. We'll kind of describe that in more detail on the next slide. Other drugs that are successful at terminating the inflammatory episode include colchicine, which is an anti-inflammatory, of course. And these properties are extremely specific for gouty arthritis. We typically see patients taking colchicine within the first 12 hours of the initiation of the gout attack, and they can feel this attack coming on. The joint gets stiff, pain starts to occur, and the patients have experienced this before. They know that gout is imminent. And it offers relief within 48 hours. And so typically the patients are prescribed colchicine and they fill it at their pharmacy, and it kind of sits in their medicine cabinet until they feel the symptoms of the gout attack coming, and then they take it, to kind of basically treat some of these inflammatory episodes that are going to be exacerbated within the next 12 to 24 hours. So low-dose aspirin, as low as 75 milligrams to as high as 2 grams, is going to produce uric acid retention. Okay? High-dose aspirin has the ability to become uricosuric. And so, if you're going to employ the use of aspirin to control gout, it's going to have to be the high-dose aspirin. And by high, we mean extremely high. Higher than, more than 3 grams of aspirin per day will inhibit reuptake of urate into the proximal tubule. You can see aspirin being employed, but it's going to have to be very high doses. And what does that tell you? The patients are going to experience GI upset, peptic ulcers, bleeding, and so forth. So, it can work, but it's probably not the best therapeutic benefit. And for patients that have comorbid conditions, it's definitely going to represent some kind of problem. So we'll use something like colchicine. Colchicine is an antimitotic. We've talked about colchicine as an anti-inflammatory or immune suppressant type drug, but it is an antimitotic in the classical sense, and it's very, very useful in these early phases of an acute gout attack. It doesn't really inhibit prostaglandin synthesis, and so it's not really a good analgesic, but it gets more into the mechanism of the cause of the inflammation. So what does it do? Mechanistically, it binds to tubulin, and it's going to inhibit that microtubule formation. Okay, that's going to inhibit the granulocytes' ability to be motile. And so if you inhibit that, you're going to decrease phagocytosis, you're going to decrease the release of granules, you're going to decrease the lysis of the granulocytes, and of course, the main therapeutic benefit is going to be a reduction of cytokine release, which, remember, the cytokines are going to be the driving force of further immune cell recruitment into the gouted joint. So you can use this for relief of inflammation in the acute phases. There are prophylactic doses that you can see being employed. These will reduce the intensity of the gout attack. The gout attack will still occur, but the intensity of it will be diminished. And so that's, from the patient's perspective, that's pretty good too. You see them being employed within 36 hours of the beginning of the attack, and the response rates are relatively good. For years, it was used off-label with no FDA indication at all. There was a clinical trial called AGREE, and there's the trial number there at the bottom, and that basically showed that the low-dose colchicine was very effective, and then there's a specific regimen in terms of the regimen and then the number of side effects that you can see as an outcome of that. So there are patients that will take colchicine daily as a prophylactic, but there's going to be side effects to that. And so the better option would be to get them on something else to reduce the severity of the attack and have colchicine as kind of like a backup for when these episodes start to manifest themselves to quickly reduce and alleviate some of this pain and symptoms. Lots of side effects. GI is the most common, including diarrhea, also abdominal pain. Remember, it does inhibit mitosis, so there's going to be bone marrow depression. It can produce alopecia. It can produce peripheral neuritis. In terms of the acute toxicity, you can see hemorrhagic gastroenteritis. You can see damage of the vascular networks, as well as a little bit of paralysis from the CNS component. So I mean, not a wonderful drug to be on for long periods of time, but definitely a good drug to be on for acute phase attacks. So the other therapeutic goal was to reduce hyperuricemia. And so what do we want to do? We want to get rid of uric acid. So you want to deplete that uric acid pool, and that will essentially prevent future attacks. And you can also dissolve the existing crystals. And so one way to do that is to inhibit xanthine oxidase. And that's the final pathway, the final enzymatic pathway as you go from purines down to uric acid. And you can inhibit that pathway with allopurinol. And so obviously the system then will produce less uric acid. Less uric acid means less uric acid deposition into the joints, meaning less incidences of a gout attack. So allopurinol is classically termed a suicide inhibitor of xanthine oxidase. And remember, that's that final pathway that I said earlier. And so essentially when you use this type of drug, you get more water-soluble uric acid, and it can leave the system via the kidneys as opposed to accumulate within the bloodstream, causing problems. So allopurinol is really the good drug to use for maintenance, and so you'll have the patients on allopurinol for long periods of time, and this will be good for the chronic grout. I need to actually grout my my kitchen. That's what I'm thinking of for the weekend. Useful in treatment of chronic gout, and you can combine it with colchicine during these flares, and that'll reduce the incidence and the severity of these acute attacks. So my mom has gout, or grout, and she's on long-term allopurinol use, and so during the holidays when she's eating all, turkey and roast beef and ham and all these other, real protein-rich foods, she knows that she should have a bottle of colchicine filled, ready for when these acute attacks come on. All right. Allopurinol is not without its side effects, though. You've got nausea and vomiting, diarrhea, bone marrow depression as well. Some patients do experience some hypersensitivity reactions after many, many months or years of usage. And of course, there are drug-drug interactions as well, particularly with anticoagulants and probenecid. So febuxostat, which is a fun word to say, is a new inhibitor of xanthine oxidase. It's a little bit more effective at reducing uric acid blood levels, and this may occur without a reduction in gout flares. I keep saying grout, Jesus. Clinical trials indicate that there's really not a need to dose adjust the patient, which is really nice if they have any kind of renal or hepatic impairment. So if there's comorbid conditions of renal insufficiency or hepatic insufficiency, this drug is extremely safe for those patients. And again, this would be great for patients who cannot tolerate, for whatever reason, allopurinol. And side effects are listed there. So as we go from hypoxanthine, this is a little cloudy, sorry about that. As we go from hypoxanthine to xanthine to uric acid, xanthine oxidase is the enzyme that can convert both of these intermediates into uric acid. So both allopurinol and febuxostat inhibit xanthine oxidase here and here, thereby reducing the accumulation of xanthine as well as the accumulation of uric acid. All right. Other drug groups that we're going to talk about include the reduction of the crystal's ability to have an inflammatory response, which we said were NSAIDs, steroids, colchicine, and other drugs such as IL-1 inhibitors, which we talked about in RA. And then there's a few other drugs that can inhibit renal excretion of uric acid so that essentially you don't drive the gout attacks. And then resburicase is a new drug class that basically inhibits the production of uric acid to make allantoin, which we'll discuss in a few minutes. So probenecid prevents the resorption of uric acid within the proximal convoluted tubule, and that's going to reduce the total pool of uric acid, all right? The only caution with this is that with high uric acid excretion, there's an increased likelihood of precipitating kidney stones. So what do? You can increase urinary output, and you can also alkalize the urine, all right? We'll use probenecid to basically reduce the urate pool. You can use it within 2 to 3 weeks after an acute attack. Probenecid is also used co-administered with certain antibiotics like penicillin and cephalosporin and fluoroquinolones. Essentially what it does is it reduces the ability of the kidney to excrete these drugs in the urine. So therefore the concentration within the plasma stays high, so the antibiotic can stay around for longer periods of time. Okay. Toxicity with probenecid, GI irritation, allergic dermatitis. There's a rare nephrotic syndrome, but it's good to know about it. There are drug-drug interactions, as we said earlier. Salicylates can decrease the effectiveness of probenecid. So, if the patient was on high-dose aspirin, that would be a drug-drug interaction right there. So you can read this on your own, but essentially this is describing the mechanism whereby these crystals basically become incorporated into these joints and essentially stimulate a very potent immune response that's mediated by what? IL-1. So again, see where this IL-1, which remember is a pro-inflammatory cytokine, can actually drive progression of a disease. This is basically justification for implementing IL-1 specific targeted therapies in management of gout. So this is a known pathological aspect, and there's essentially 3 available interleukin-1 antagonists out there. Anakinra, we talked about. They've been using it basically off the record. There really hasn't been a clinical trial, as far as I can tell, since the last time I looked in 2015. But it's still commonly employed for some of these persistent gout attacks. Rilonacept had a very small clinical trial, but reported success in these gouty patients. Canakinumab was essentially used in gout patients, and that's kind of where the standard therapy was essentially contraindicated. So canakinumab has European Medical Association approval for gouty arthritis. You should see a similar story in the US pretty soon, I would imagine. So there's quite a few clinical trials out there looking at interleukin-1. So, as I said before, with rheumatoid arthritis and with gout, you'll start to see these targeted therapies employing some aspect of interleukin-1 targeting becoming more and more prevalent. And actually look at this, they're comparing some of these drugs with your NSAIDs, with other drugs that we haven't really talked about in terms of their ability to control gout. But triamcinolone is another drug within that category that has been shown to offer some benefit in terms of controlling some of these gout attacks. Excuse me. So the way uric acid gets absorbed is really through these organic anion transporter proteins, and there's several different kinds within the renal system. Probenecid and some other drugs have the ability to inhibit that. And so what you can do is you can actually inhibit the ability of uric acid to be reabsorbed and basically shunt it into the kidney so that you essentially pee it out. Another drug category that's coming out is resburicase, and it's actually not a drug. It's an enzyme. It's a protein. It's a recombinant form of the enzyme urate oxidase. And so what happens here is that it catalyzes the oxidation of uric acid into allantonin, which is essentially inactive and it's soluble. And so this is really good because now you can essentially convert uric acid into something that has no pathologic consequence, all right? And that'll offer some relief because remember, that's the thing that's really driving this gout formation. You can see this in a couple of different indications, which are described here. There's also an indication for this type of drug in cancer therapy, addressing the tumor lysis syndrome. But generally, we see a dramatic reduction in plasma uric acid levels within 24 hours. And so you see a reduction of 70 to 90% of uric acid coming out within the first day of therapy. But there might be a hypersensitivity reaction, including an anaphylactic type reaction, which you have to be aware of. There is a risk if the patient has a G6PD deficiency. So therefore, now they're recommending that if you're going to initiate patients on resburicase, you should screen them because you don't want to have hemolysis syndrome. Patients of African or Mediterranean ancestry have this component to them, so it's something to kind of be aware of. And there's some assay differences with this drug that would really be used in the management of these patients that you can read about. There's a few new agents that are in the pipeline. The first one, our halofenate, is made by CymaBay. It just completed phase 2 clinical trials, and so you'll start to see these types of drugs coming out in the next couple of years. These drugs lower serum uric acid by essentially blocking that uric acid transporter within the kidney, and this leads to a relatively high increased excretion of uric acid into the urine. They've been looking at it in terms of a combination type regimen with febuxostat. Only reason I know this is because my cousin-in-law works here, and he was touting the usefulness of this drug at our Christmas party a couple months ago. So this, I don't even know if it's even in the newspapers yet. You know, so what I kind of summarized here is if you've got a situation where, you know, you've got a compounding or comorbid condition, there's going to be some limitations to pharmacotherapy. So, you know, let's take renal insufficiency. So if you've got a patient that has gout and they're renally compromised for whatever reason, NSAIDs are probably going to be a tough therapeutic benefit because they're going to exacerbate some of that renal damage. All right? And so the alternative is, well, you can use colchicine, but you should maybe reduce the dose. You can employ corticosteroids for these acute flares. If the patient has, you know, a history of peptic ulcer or some type of GI inflammatory disease, colchicine may actually cause a little bit more GI upset, so maybe you might want to rely on corticosteroids. And so, you know, I know from when we talked about some of the nuances in the cardiovascular unit, you guys were kind of craving knowing, you know, the judgment calls in terms of which drug would be better. For this particular lecture series, it's a small lecture. I'm not going to beat this to a dead horse, but here's kind of the information so that I know there's a little bit of disparity when you look at all these different drug classes and, you know, one disease. So this is something that, you know, hopefully you can kind of use in your arsenal in terms of how you might approach some of these cases when you see them. But, you know, for where we are at this point, we just want you to know the major drug classes for these diseases and what the molecular target is and why it's a molecular target in terms of the pathogenesis. Okay. You know, so in terms of gouty arthritis, this is a really nice kind of a summary diagram basically showing the inflammatory component and the essential, you know, molecular targets for each of these drug classes. So I really like this kind of slide as a kind of a summary thing. As you're studying, you can kind of trace through all of the different pathways and see where some of these drugs will have the most therapeutic benefit. Obviously of note are the IL-1 or the anti-IL-1 therapies, corticosteroids, which we didn't really get into, but, you know, have some clinical use in the management of gout. Colchicine, of course, looking at the vascular endothelium, as well as NSAIDs mediating or inhibiting the inflammatory mediators that are driving some of these reactions against these crystals. Okay. So that's it in terms of inflammation, rheumatoid arthritis,